The following is a presentation of Project Independence and WCWP. Project Independence is the Aging in Place initiative of the town of North Hempstead.
Welcome to Project Independence and You.
Good morning and welcome to Community Talk Radio. This is Project Independence and You on LIU Public Radio. I'm Rebecca Miller, along with co-host Otto Lohse and show producer Kristina Lew. So how are you today, Otto?
Good morning, Rebecca. You've recovered from your little journey?
I have. I'm sure we'll be discussing that later. But
yes.
The exciting news is we're back at the LIU radio station, and we're recording today. Today is, what is today?
Opening
the 27th? And so when our listeners hear the show, it'll be Friday, the 29th. But I don't want to, with any further ado, our guest today is Dr. Brian Mayrsohn from Maywell Health, and he's here to talk about comprehensive pain management. So first of all, thank you so much for joining us today, Dr. Mayrsohn. It's great to have you.
It's my pleasure to be here. Thanks for the opportunity to share my story and my vision and passion for pain management.
Yeah, we'd love to definitely hear about it, because you hear a lot about pain management, and I think everybody has kind of a view on what they think it is, but reading through all the material and just kind of knowing a little bit more about it, there's so much more than just kind of managing medicine. And the good news is that there are other ways to kind of manage pain. So what did kind of drive you to this specialty?
So, yeah, there are so many ways to manage pain management, and the specialty is very collaborative. I grew up in a household of physical therapists and psychotherapists. So my mom, Sherry Mayrsohn, always said, don't be one of those doctors who just writes for prescriptions or does surgeries. Look at the whole person. Look at the whole person sitting in front of you. So that was kind of the mindset that I had going into college. And that was very involved in public health and nutrition. So I went on to get my master's in nutrition at Columbia, and it's there I learned the value and the impact that prevention can have on the body. I found that pain management was a way to combine all of my passions for prevention, for whole person pain medicine. We work with nutritionists, psychotherapists, physical therapists, acupuncturists, chiropractors. It gives you a chance to be a kind of a primary care doctor for the musculoskeletal system. And that's what so I think pain management has a chance to really revolutionize the way that we deliver healthcare.
That's a great explanation. And, I think a lot of people think of pain management as you go to when there's nothing else to do, like you're in pain every day and you've done everything. But kind of what you're saying is to preempt it. And how do we know when it's time to see a pain management doctor?
Yeah, that's a great question. I think the paradigm was, surgery failed, physical therapy failed, everything is failing. Now let's just rescue this person and try to see how can we salvage their pain. And I think it needs to be the opposite of that. I think the pain management physician can be the quarterback for your musculoskeletal health. So if you have some injury, our profession we're experts on navigating this field. So we can connect you to the physical therapist, whether it's an orthopedist or an acupuncturist or a nutritionist. So that because we all know that healthcare is very challenging to navigate, and you need to have an advocate who understands the system, who can argue on your behalf and connect you to the right people. So I just see pain management physicians as the perfect type of doctor to help that process along. So even if you have an acute or a short-term injury, whether that's like an ankle sprain, it's great to know that your primary care doctor can be that reference. But if you don't have someone that can get you into physical therapy or the orthopedist or even just pain management, I think having a good pain doctor on your team is vital.
Right. I like how you're saying team, and comprehensive. So it's really not just about one part of recovery or preventing. It's about the doctors that you go to working together.
Yeah, exactly.
I don't know of too many people that do not have some sort of pain. Uh, and you mentioned musculoskeletal health. Does that also include like the nervous system? Um,
Yeah, that's a great point. So musculoskeletal health, I would say in the medical term, should include the nervous system. Um, so muscles, bones, nerves, all of these components have receptors that can trigger pain. So as a pain physician, we handle essentially anything that causes pain, down from headaches to neck pain to chest pain, abdominal pain, spine pain. But it's important to understand that each of these different pain areas has different experts that can weigh in. So if you were to present to me with chest pain, obviously my first concern is it a heart attack? Do we need to get you over to a cardiologist or the ER? But after the chest pain is ruled out from any heart issues or myocardial issues, then we have to determine, all right, well, is it musculoskeletal? Is it the ribs? Is it the esophagus? Is it acid reflux? So then we can help figure out, well, is it a gastroenterologist that you should see, or are you in the right place and we have to treat you for a musculoskeletal issue?
so you're more of a person who's kind of diagnosing the pain and trying to analyze the best track to go on, and then you have like people you work with who you can direct them to. Is that
Exactly. So that's what physicians are really good at, right? We spend 4 years in medical school, then another 3 to 7 years in residency training, and then an additional 1 to 4 years in fellowship. So as a pain physician, I went to med school for 4 years, residency in anesthesiology for 4 years, and then an extra 1 year in pain fellowship. That was over at Cornell and HSS and Sloan. So we accumulate this body of knowledge so that we can diagnose patients and then help figure out, can I help this person or can someone that I work with help this patient?
I think that's a good thing. What would be, uh, with your experience, like the top three causes of pain or diagnosis that you come up with?
Yeah, I think it depends on the age of the person that I'm in front of. So if we had somebody who was in their teens, 20s, and 30s, headaches and neck pain is probably the most common, which is highly associated with stress in the workplace, stress in the home environment. And we handle stress differently. Some people say that, oh, I wear my stress on my shoulders. Well, it's true. We have very tight trapezius, tight sternocleidomastoid muscles. So these muscles get very tense and they cause referred pain to the face. So there's a very famous physical medicine clinician named Travell, and she created a book, and it's been in the physical therapy world for 50 years. And these Travell signs are trigger point signs that refer pain to the face. So understanding how the muscle system works and how it impacts pain throughout the body is important. And that's what pain doctors are really great at. And not just pain doctors, right? Physical therapists, physiatrists, and orthopedists all have similar training in musculoskeletal medicine.
Um, what would be the next one, like going up? Maybe what I'm leading into here is I know an awful lot of people have back problems.
Yeah. Yeah, that's a great point. Thanks for bringing me back on topic.
I'm sorry.
So people over the age of 40 tend to have low back issues, herniated discs. People over the age of 50 tend to get more of the arthritis of the low spine and of the neck. So then we're talking about neck pain, low back pain, and knee pain. Those are the three most common causes of chronic pain over the age of, let's say, 45.
So what do we have to look forward to,
Yeah,
Dr.
right.
Brian? I'm like, okay. Does it like just go up until like, just lands everywhere between?
Oh my gosh. So yeah, I think a lot of this then comes to prevention. Coming from a very strong physical therapy family, I think that it's very important to have the right core strength, the right posture, the right attitude every day to help decrease some of the stress that you experience in the world. So depending on what type of job you have, having an ergonomic conversation with your team such that your computer is eye level, such that your chair that you're using is the proper 8-hour or 12-hour chair that has lumbar and cervical support, getting up frequently throughout the day, eating right, drinking enough fluids. There's a huge prevention conversation that has to happen to help so that you're not in all this pain in your 50s and 60s and you can enjoy your life. But that's also what pain doctors come in and help. We help take away a lot of that pain that you experience so that you can get back to all the things that are fun and engaging.
Yeah, I was going to say, like, if prevention is too late, you already have the problem, like a back problem. What would be the typical path you would go on with somebody in that category?
So we would do a few things. One is what's called an HPI, history of present illness. So we'd ask a ton of questions about the type of pain, the symptoms, what you've tried, what medications you're on, to truly understand what the story is. Because if you just listen to the person sitting in front of you, 90% of the time, you know what the diagnosis is. So we combine the HPI with a physical exam. So we do a low back exam, a neck exam related to the pain at hand. And it's important to also look at the joints next to so above, below, and next to what's causing pain. So let's say it's your low back that's in pain. We really should be also looking at the hip and the knee, making sure that those joints are acting appropriately and that biomechanically that they're structurally intact. Because pain, just like the neck pain that refers to the head, you can have referred pain of the hip to the low back and vice versa. So the physical exam, the HPI, and then imaging, so MRIs, X-rays, CAT scans, holistically helps us figure out what the diagnosis is. So if you had low back pain and it was a herniated disc, then we would say, okay, well, the mainstay is physical therapy, maybe an Advil, like an NSAID, a Tylenol. And if pain does not improve over the course of a couple of weeks, then we can consider an injection like an epidural, which is a steroid shot into the low back. But it's important to understand that when we do these injections, we're not fixing the underlying problem. We're just creating a window of pain-freeness, so that you can go back to physical therapy and strengthen yourself. The body naturally wants to heal. So if someone says, oh, I had an epidural, it lasted 2 years. Epidurals don't last 2 years. They last 3 to 6 months. Really what happened was you got the epidural, you did the physical therapy, your body healed itself. So I want to take all the credit that my epidural lasted 2 years, but I really can't. It's that you did what you had to do. You went to the physical therapy, you trained in posture retraining. Now, if you come back to me in 3 months and say the epidural lasted for just 3 months, I didn't do the other stuff, well, then your body didn't heal itself. You need another epidural, and we got to send you back to physical therapy. So that's why it's so important to work as a team so that we can get you better and out of my office and back into your life.
I just wanted to ask, because you had mentioned this, herniated discs, ruptured discs, whether they're in your spine or lumbar or your cervical spine, do they ever heal? I mean, you hear ruptured disc. It's such a scary thing to hear. I have in my cervical spine years ago, and I feel like I'm better, but do those ever truly heal? Like, what happens to the disc if it's ruptured versus herniated?
That's a really great question. I think a lot of these terms are used in different ways, but really we're all kind of saying the same thing. Now, medically speaking, like a herniated disc versus a bulge is slightly different, but basically the disc, you're basically born with the disc that you're going to have. Once you hit age 21, right, the disc is fully formed, you're fully grown, you're not changing. And because the blood supply to the disc is not that vascular, like if you were to cut your hand, you'd have lots of blood. If you were to cut your disc, blood's not pouring out of that disc because it's just not filling with that circulation, which means that the healing of it is not going to be as robust as, say, your hand. So when you have a ruptured disc, when that disc material leaves the disc, similar to a jelly donut, if the jelly leaves the donut, you can't put it back in. You already ate it. So the disc material leaves, the body will clear that disc material or that jelly donut consistency, but what's left over in your disc stays. So in other words, if you have a disc herniation, your body clears what herniated, but what's left behind is the leftover part of the disc. And over time, more and more herniations can occur, and you'll lose more and more disc material. And eventually, the whole disc is just totally gone. So that means that the spine starts to collapse on itself. So when people say, I've lost 3 inches, well, it's because you've probably had multiple disc herniations. So over time, the spine loses the disc height. And or you've had fractures within your spinal column on the vertebrae. So as we get older, we get osteoporosis, and then there are fractures that can occur on that vertebrae. So you can lose vertebral height, which is separate than disc height loss. So I had a patient yesterday who lost 2 inches, but she has perfect vertebrae. She just has lots of disc herniation, so she's lost the height from the discs.
And is it true that unless that disc or the bulge is impinging on a nerve, we may not even know that we have, issues with the disc?
Yeah, that's really interesting. So if you scan 100 people over the age of 50, you're going to see all sorts of disc herniations, and they're going to say, I'm not in any pain. How is that possible? And that's why you can't just treat the image. You have to look at the history of the present illness, their symptoms, their strength, their weakness, and look at the imaging. So that way you're really guiding the treatment based on the person in front of you, because you're right, you might not have any pain with a disc herniation.
Okay. We actually have to take a quick break. And after the break, we'll continue talking to Dr. Brian Mayrsohn from Maywell Health, all about comprehensive pain management. You're listening to Project Independence in You on LIU Public Radio.
Take WCWP with you wherever you go with the WCWP app. Listen live 24/7 to all of our streams, all from one app. Plus, call the studios directly from the app and visit our social media. Download the app through the iOS App Store on Apple devices or the Google Play Store on Android by searching WCWP Radio, or visit WCWP.org for links. The WCWP app, available now on iOS and Android devices.
Welcome back to Project Independence in You. I'm Rebecca Miller, along with my co-host Otto Lohse and show producer Kristina Lew. We're speaking to Dr. Brian Mayrsohn from Maywell Health about comprehensive pain management. Great first segment, learning a lot about comprehensive pain management. I'm curious because what's the advancements that we've seen over the last few decades? Because I'm sure with technology and all this teamwork with different specialists seem to have brought it into the mainstream more now.
Yeah, pain management has really undergone a transformation, especially over the last 10 years. We're seeing that there's a lot more procedures and even minimally invasive surgeries that are entering the space. Similar to what happened with cardiology over the last 30, 40 years, where they've moved to minimally invasive heart valves being placed non-surgically. We're seeing that with pain management now. So patients that have spinal stenosis, now they can have lumbar fusion surgeries through a very tiny incision, devices that are placed in the back of the spine that have a much shorter recovery time. Other devices like SI joint or sacroiliac joint fusion, which are placed posteriorly, whereas in the past they were placed laterally, requiring a 3-day hospital stay. Pain management physicians are now using a posterior approach where patients can go home the same day. There's spinal cord stimulation, which is a electrode that's placed just behind the spinal cord in the epidural space. Now we have new technology using artificial intelligence and what's called closed loop technology. So there's a company whose name is Saluda Medical, who was the first one to market with this closed loop system. And that basically means that the system can listen to the electricity that it imparts on the spine and adjust itself in real time. So we really are having a renaissance with technology and implants that I think is changing my field dramatically. Obviously, the opioid epidemic was a really big shock to the system that, obviously had tremendous negative implications. But we're seeing that the pendulum may have swung too far. So now that there are patients that don't have access to certain medications that they might otherwise need. So it's important that we continue to advocate, for our patients, whether it's for these new implants so that insurance covers it, and even so that they have access to the right pain medication, because now there are shortages of these pain medications. There's caps and quotas on what can be created. Pharmacies aren't filling it. They're not stocking it. And patients are now being treated really unfairly. So we really have to find the right balance of technology and medication management in this new era.
Right. That's a great point, because I've been to, a few doctors, and they have signs up saying that they don't even give pain medicine, and it's not what necessarily people are going there for, but that's kind of what you see. Right. That,
Yeah.
I think that does need to change.
Well, I mean, I know people who've had knee surgery, knee replacements, whatever. And when you start talking about pain, they kind of pull back. It's like their job has been successfully done mechanically, and that's it. So, you're sort of on your own. Would you get involved with post-surgery situations, where it could be knees, it could be lots of things, really?
Yeah, I think you're opening the door to an interesting point. So a lot of pain doctors are anesthesiologists, and that means that we're perioperative physicians. So before, during, and after surgery. So as a pain physician, I think our role isn't just after surgery if you're in pain, but it leads up weeks or months before surgery. So let's just take a patient with hip osteoarthritis. Let's say that they're very weak, they're in a lot of pain, they need to have a hip replacement. We know that physical therapy before surgery leads to better outcomes. So there's something called prehab. And it's hard, though, to go through prehab if you're in pain. So seeing a pain physician to help decrease the pain that you're experiencing, whether that's through medications or injections, can help decrease your pain, go through to physical therapy, strengthen so that you have a better outcome after surgery. Now, getting to your question, though, post-operatively, of course, I work collaboratively with surgeons to handle their post-operative pain. Some surgeons like to handle the pain within 7 days. That's the acute pain. But then if there's still pain lingering beyond, then they'll hand the patient off to a chronic pain physician to help with prescriptions or maybe other injections afterwards to help decrease that pain experience.
You mentioned a few times physical therapy, quite a few times, actually. And you also used the word attitude back a little further. To me, there's a combination there of physical therapy and attitude. I know people who should be doing physical therapy, but then they say, well, the pain is too much and I can't really do the physical therapy. So it's like a catch-22. That's I don't know if you can make people do physical therapy, but you can try to encourage people, I guess. Would you get involved with that?
Yeah, I think encouragement, motivational interviewing is all part of what it takes to be a clinician. The physical therapist's job is part of it is being a cheerleader. And the physician's job is also being the cheerleader, encouraging them to go to physical therapy and using any strategy that we have to motivate or excite somebody about that rehab experience, which is why having tools in your tool belt to help decrease pain, to get somebody out of that funk, right? I had mentioned before that as a pain physician, we can create a window of a pain-free time. And if we can get them out of pain for, let's say, 2 months, that's when we get them to physical therapy, start working hard so that they can recover themselves. That way, going into surgery, they are stronger, or maybe they don't even need surgery if they've recovered. People would be surprised how much surgery could be prevented with the right pain management and physical therapy team.
Yeah, but I think people have to understand that they have to be part of the process, and they're
Absolutely
important in the process. I think you have to be a willing patient.
You do. And we're always trying to find ways to get people motivated and willing. which is kind of getting to another point, right? Is that people that live in pain have anxiety, they have depression, they have other pieces of like what's called catastrophizing behavior, where they focus on their pain and they ruminate about their pain. So it's important for us to identify people that have these afflictions so that we can get them to the right counselor or therapist or psychologist or psychiatrist. So I screen all of my patients for these conditions, and I talk to them about how their condition can influence their pain and decision-making process. But that's a very tough conversation, because people don't want to feel like you're telling them it's in your head. So it's important to balance the way that you deliver that information, because it's real, and we need to keep that patient trust in that conversation and buy-in, so that they know that it's okay to, move on to that next healthcare professional if need be.
Do you ever get into situations where you wave the white flag and you say, we can't really get rid of this pain? It's going to be there. I know you may not want to, that may be a negative direction, but I'm just curious as to, do you always score a touchdown, if you will?
Yeah, that's a really good point. No, you don't always score a touchdown. Sometimes you just get, a 10-yard line. Maybe you get a 5-yard pass. Sometimes you get tackled. I think just being open and honest through all the conversations is important, so that the patient or the person that you're with understands what decisions you're making, why you're making them, and have them being part of that conversation. So I kind of view my job as an educator and empowerer, so that the person that I'm working with can help make the best decision for them. And I think sometimes the conversation isn't about always getting to, no pain, because that's really unrealistic sometimes. I think objectively we can get someone so that their goals are met, where they're playing with their kids or grandkids, or partner, that they're going outside for walks. So it's really trying to figure out what goals they want to meet and helping them get to those goals. I think there's always a way to improve the quality of life, and that's through the multimodal approach.
I think sometimes people's expectations of recovery isn't realistic. Like, even when you go to a doctor, Otto, we talked about this. Sometimes you'll go to an orthopedist and they've done a splendid knock-up job on that knee replacement. It is the best. Everything's in place. But from that point on, you then maybe go to physical therapy and you may not have contact with that doctor. So when you're going in for a surgery like that, I feel like there should be a realistic timeline from, surgery to a realistic, recovery point, or at least what the best and worst expectations could be. So people, I think, don't really understand, am I going to ever be 100%? Maybe it's going to be 80%, and that's pretty good. But there's kind of not that communication about that timeline. And I know, Otto, we've talked about that.
I agree 100%. I mean, realistic expectations, I think, would make a big difference, because some people get a knee replacement and some hop right out. Some get a knee replacement and it's agony. They ought to point out that could happen, and we'll try to minimize that. But, here's the real story, as opposed to some fairyland story about how it's going to be just wonderful and you're going to start tap dancing and
right. Like if somebody said, hey, we're not going back to 100% when you were 25 years old. We may be going back to 75, but that's good. Just that realistic outlook. So you're, when you get to 75, you're not still looking for 25, and you might get there, but there needs to be those kinds of, that kind of understanding and timeline. And
100%.
Surgeries. I'm sorry. No, you mentioned different surgeries and whatnot. Are you affiliated with any hospitals, or do you work with several hospitals?
So I'm affiliated with the NYU system and the Catholic Health system, and also the Mount Sinai Hospital system. But affiliations don't necessarily mean what one would think that they mean. Right? Like, I'm not a professor or a teacher at those hospitals, but I'm allowed to perform procedures or have patients at those hospitals. So I think it's important to be affiliated with as many hospitals as possible because you want to provide options for people. Some people have all their records in one system and they want to stay in that system. But in the modern day private practice world, hospitals are definitely trying to, gobble up as many private practices as they can and grow and expand. And it's definitely becoming a challenge, I think, for the private practice community to withstand the encroachment of those hospital systems. And it kind of gets into a little bit about what you were talking about just now about the lack of or poor communication that happens to patients about surgery. While that could happen, I think the result is because doctors are forced to see so many patients so quickly. So the time with someone is decreased. So we have to be creative in how we can educate and communicate outcomes to patients. And that could be through educational videos, because we're looking for ways to see as many people as possible to maximize care. What's interesting is getting not too off topic, but the insurance reimbursement rates are different for a private practice physician than if you worked within a hospital system. So the same doctor can work in a hospital or in a private practice, but they might get paid 3 times as much if they're in a hospital setting. So the financial model is just incentivized for hospitals. Yet, it's my opinion, I think many would agree that you might get a better patient experience in a private practice where when you call, you get the front desk, you get the office manager, and the physician picks up the phone very quickly. We can get you in the same day or next day. So there's almost this like anti-competitive behavior that's occurring on the hospital system side, and it's preventing choice for patients in the community.
I have a good relationship with my own doctor, and I'm not going to mention the systems that they're connected with, but you mentioned a couple of them. And one of the problems that she admitted to is that they are so micromanaged in one particular system that it's really difficult to do your job, and they actually split away from that system because of it. Again, I'm not going to get into that. But
yeah, it's incredible. If you look at the trends of physicians hired versus administrators hired, the number of physicians, the trend line is, less than inflation rates, whereas the administration increase in volume is hundreds of percent year over decade over decade. So there's all this bloat in the system that's been occurring, and that's driving up the cost of healthcare and just leading to physician burnout. There's really a ton of problems, but truthfully, that's what excites me about healthcare, is that there are so many problems, that there's so much opportunity to solve really tough problems that can be, if solved properly, can change the way that clinicians engage with care, that patients engage with care, and that can overall have better outcomes.
I think even if you look at insurance companies today, they're paying for acupuncture and massage therapy. So there is, I think that end of it is happening. What if the insurance company's on? I mean, that's really helpful if you have insurance and it covers that.
Yeah, they're definitely open-minded now. They're covering nutrition services, massage, even gym memberships. I think they're realizing that there's a safer, less invasive way to treat patients, and we have to embrace that.
Yeah.
Now, your practice, Maywell Health, do you take insurance like Medicare and
Yeah, absolutely. So I'm in most of the major insurances. I do accept Medicare Advantage plans. Interestingly, I applied to get into the Medicaid plans, and they said that there were too many doctors on their rolls. So a bunch of those plans aren't accepting pain doctors in the Long Island and New York City. So I was surprised to see that. But my goal is to build a business that is scalable. And the only way to build a scalable pain management practice is to take insurances to affect as many people as possible. And I'm trying to find a way to marry technology with personalized care, and bring it together so that we can scale care, but not take away the human element of that patient-physician interaction.
That's a
So
great
that's our
topic.
mission.
If we could revisit that when we come back, we have to take a quick break.
Absolutely.
So you're listening to Project Independence in You on LIU Public Radio. We're speaking with Dr. Brian Mayrsohn from Maywell Health about comprehensive pain management, and we'll be right back.
WCWP is your home for great music and great conversation. You'll find all that and more on WCWP.org. Listen live on the web, check out the lineup, subscribe to podcasts, and stay up to date on the latest station events. Get in touch with us and let us know if you like what you're hearing. And find out how you can support or get involved at the only community public radio station serving Nassau's North Shore. Plus, sign up to get a free bumper sticker. It's all online at WCWP.org.
Welcome back to Project Independence in You. I'm Rebecca Miller along with Otto Lohse and show producer Kristina Lew. We've been speaking with Dr. Brian Mayrsohn from Maywell Health about comprehensive pain management. So right before break, we were talking about utilizing technology with pain management, which is very interesting. So I'd love to kind of delve a little bit more into that.
Yeah, there's so many places that we could start, but I think that technology has a way to track people's improvement. And if we're going to prescribe a medication or an injection or a regimen to, say, physical therapy or acupuncture, we want to know that what we're doing is actually changing someone's life, that we're moving the needle. And it's not always measured in pain score from 0 to 10. It's measured in how many steps are you taking? Are you being more social? Are you going to dinners with your friends? Are you playing sports? Are you picking up your kids? So there are new technologies to help us track these outcomes. And they're already being worn by people, whether it's your cell phone, tracking accelerometer data, geolocation data, your Apple Watch, tracking exactly heart rate variability, just heart rate, steps, EKG. So there are these new platforms that are being created and new CPT codes that physicians bill insurance companies with that are enabling this tracking of patient outcomes. So there's something called RTM, or remote therapeutic monitoring, or RPM, remote patient monitoring. So there are these new technology platforms that are allowing physicians to track patients beyond their clinic, so that we can get access to knowledge and information in continuous fashion rather than waiting for someone to show up once every 6 months. We can intervene much faster and respond a lot quicker.
You know, for you to intervene, obviously somebody has to be able to contact you. You know, typically, would you be contacted directly, or would you get contacted via another doctor, or both ways?
All the ways. All the platforms work differently, and you have to find what solution works best for your practice. So there's one solution, for instance, that will send you a text message every morning. You know, Otto, how are you feeling today? On a scale of 0 to 10, you could do pain, you could do emotional state, anxiety. How many medications are you using today? Oh, you're having an uptick in medications? A nurse will call you immediately, check in with you. How are you feeling? Do I need to get you in touch with the doctor? So that's a more proactive system. Some systems are much more passive. I think a more proactive approach is probably the best, just to keep everyone engaged. But that would be a way to determine, is someone having more pain? Can I prevent a visit to the emergency department now? So now there's a cost savings piece, a time piece. And now if you don't go to the ER, there's less risk that you're going to have a medical error occur to you, acquire an infection when you show up to the ER. So there's downstream consequences, positive consequences of the actions of intervening early.
How could we contact, if I wanted to go to you for a diagnosis, how could you be contacted, and where are you located?
So if you wanted to come to Maywell Health, I would just call 516-200-4814, and that's how you get access to us. Once you get plugged into our system, we have a remote patient monitoring system and a remote therapeutic monitoring system that does exactly what we're talking about to deliver this continuous care. We're in Long Island and New York City, and hopefully growing and expanding beyond.
Do you have a website?
We do. It's maywellhealth.com.
Right. Actually went on it.
Maywell Health.
If people wanted to look about various pain conditions and possible routes of helping those problems. So, you have a long list of options as far as pain goes.
It's incredible. All the things, all the diagnoses that drive pain, and pain physicians are perfectly suited to handle essentially all pain conditions. And the knowledge that they have of the people in the field allows us to, if we don't know the answer, we'll connect you to someone that does. That's why I think it's important to have us in the beginning stage rather than the end. So many times I have patients that have seen 18 doctors, and if they had just seen me first, or at least second, we could have prevented all of this confusion, especially amongst patients that have hypermobility, right? There's patients with hypermobility or pelvic pain. They're seeing all these specialists and they're bouncing around looking for diagnoses and solutions. And they come to us and we have a solution that's rather simple and straightforward. And I hear all the time, I wish I was here sooner.
Right.
You happen to be in the same building as my primary doctor and my cardiologist.
You'll have to stop in, Otto.
146, right, Manetta Hill Road. I think there's 146A and B.
Yes, there is. There's 146A. It's an incredible building. We have great physicians in that building as well.
And B, and then they're also connected with Catholic Health, CHS.
Yeah, right upstairs is Catholic Health, and right next door is Lenox Hill Radiology. So right when you're done with the visit, you can go right over and get immediate walk-in X-rays and schedule an appointment for MRIs or CAT scans. It's very easy and low barrier to entry, and just a really nice service that we're trying to create. We want to bring back old-fashioned service in medicine, and it's really, I think, refreshing when people come in and see the experience that they're getting.
Well, that's great. And I think being on the radio show and talking about it, and our listeners who are older are, hearing this, and it's good to hear. But, I have this question. It's like, most of our listeners are definitely older, and those that are going to be watching the show on North Hempstead Television and listening on the radio. Aside from major illnesses, most seniors and people, as we get older, have arthritis, tendonitis, things like that. And those are things that you just do have to live with. And there's over-the-counter medications. But, I've seen, and I'm not talking about serious like rheumatoid arthritis, but people who do get chronic pain from arthritis and tendonitis. What can you do about it aside from always taking an Advil or taking an over-the-counter medication? And would that be something you would treat?
Yeah, that's a great question. So arthritis, depending on how you want to treat it, can be treated with surgery if it's, say, bone on bone and you're falling. But if you're not at that late stage, other than medications, there's injections, like a steroid injection. There's stem cell injections. There's PRP, which is platelet-rich plasma injections. There's viscosupplementation. So those are gel shots that can go into the knee. And then there's radiofrequency ablation. So we can actually deactivate the nerves that are causing pain. And you could do a RFA, or radiofrequency ablation, of the neck, the shoulder, the hip, the knee, the low back, and really almost any peripheral nerve in the body. And there's different ways to do it.
Frequency ablation?
That's radiofrequency ablation. And there's also cryoablation. So cryoablation is when you freeze the nerve, and then radiofrequency is when you heat it up. So there's two different approaches, and they both have different degrees of effectiveness for different body parts.
I actually had very successful radiofrequency ablation and an aroma in my foot. And I was extreme pain for years. And, I was having all kinds of injections. And then I had this procedure and it was gone. was amazing. Is that something you do in your practice?
Absolutely. And we do radiofrequency ablation in the office without general anesthesia or any sedation. It's just local. So we use lidocaine. So the experience is pleasant. We put some music on, and some patients say, I didn't feel anything. I don't even believe that you did anything. So sometimes I say, maybe I shouldn't use so much lidocaine, then maybe you'll feel that things are changing. But I still like to provide a nice experience. So I won't do that.
Yeah, it was unbelievable.
Yeah.
Kind of changed my life. And, I was awake too for it. I had
Yeah. How long did it last for, or is it still working for you?
Still working. You mean it's not going to work forever?
Well, how long ago did you have the procedure?
Years before.
Years.
COVID. Yeah.
I don't think it's going to come back for you. Okay. Typically, radiofrequency ablation can last 6 months to 1 year. The nerves do grow back over time. Sometimes the pain comes back, sometimes it does not. And if it does come back, we can just do another ablation. So some people come back every year to have their low back or neck ablated.
Mm-hmm. Okay.
How about something like neuropathy? I hear a lot of people with neuropathy in the older years.
Yeah.
Is that something you get involved with, or?
Absolutely. If you're in pain, we treat it. So pain physicians are hackers. They're hackers of the human body. So the nervous system is like a big computer, and we're trained to hack the nervous system. So if you have neuropathy, so that would be a painful nerve from maybe diabetes or chemotherapy, or just some sort of surgery or trauma, and now there's nerve injury, we can do all sorts of either medication management, injections, or devices. So there are seizure medications like gabapentin, Lyrica, or antidepressants like Cymbalta or venlafaxine that can modulate these nerves. Then there's the steroid injections, which can decrease inflammation and get rid of nerve pain. Then there's spinal cord stimulators, which you can place along the spinal cord just behind it, and that can trick the nervous system into thinking it's not in pain. And then there's peripheral nerve stimulators, which are stimulators that you can place anywhere in the body near nerves that can, like a TENS unit, can trick the body into thinking it's not in pain. So there's definitely lots of solutions that one can consider. And this is why I talk about education and understanding someone's goals so that we can figure out which solution is right for the person in front of me.
Oh, good.
Yeah. I mean, I think we should mention your phone number again, because I think people listening are hearing what you're different points, and I think connecting to it, neuropathy and arthritis, and certainly are a lot of conditions that are affecting a lot of our listeners, if not all.
100%. Well, thank you. So I'll plug it again. It's 516-200-4814.
Okay. And if you're listening and you've missed the phone number or any of the contacts, you can always reach out to Kristina or myself at Project Independence by calling 311 or 516-869-6311. So
thank you so much for the opportunity to be here. I really appreciate it.
Oh, it's great. It's great to have you. I think we still have a few more minutes with the show. We have about 5 more minutes.
Okay.
I'm just interested to, your mother, who is with Metro Physical Therapy and a great friend and partner with Project Independence. And you talked about her influence, which I loved hearing, and that put a big smile on my face at the beginning of the show. Is she aware of how wonderfully you speak about her?
I think so. I try to remind her how awesome she is, but I talk about her a lot behind her back, how good she is. I should probably do it more to her face, though.
Let me tell you, as a mother, I think you should.
Yeah, no, she's an incredible person. Definitely very inspirational, and has motivated her whole family to just propel. So she has 3 sons. So my brothers, one of them is a physical therapist. He's the CEO of Metro Physical Therapy, has done incredible work growing the company and expanding. And my other brother is a psychotherapist. So he started his own practice as well, and he has 10 therapists that work with him. So the 3 of us are budding entrepreneurs in the health space.
Real underachievers, huh?
Very under, yeah, exactly. Well, because we all have, anxiety or OC, something that pushes us. We don't like to be bored. We just got to keep doing stuff, and it's just fun. If you get to do fun work, then you're not working. You're just having fun with people that you like to hang out with and make a difference.
But by the time you get through with all the years of school, 4 years this, 3 years there, internship, whatever, it's almost time for
Yeah. I would love to be retired. Yeah, set me up. No, it took 11 years. It took a long time to get through, and now I'm finally unleashed. So we started the practice August of last year. So we saw our first patient October 15th, and it's been 5 months, and we're already having patients who we were treating in October referring friends based on their outcomes that they've experienced. So we're getting really great results. And it's great to see how things are changing.
Well, I saw also on your website, you can make appointments online.
Yeah, you can make appointments directly on the website at maywellhealth.com. You can call the website and we'll be standing by. And right now, if you join the practice after 5 p.m., I still answer the phone myself, but I'm told I have to stop doing that. So after 5 o'clock, the phone will go to an answering service.
You can't stop for at least a few weeks after this show airs.
Yeah, I'll keep it going for another month.
Have to answer.
Now, do you also, typically if somebody's a first-time patient, are there forms online that you can fill out?
Absolutely. So there are online forms that will sync right into your medical record. So I know that people get frustrated. They fill this form out and they wonder where it goes. Well, it's going to go right to your medical record and you will not get asked that question again. So we're streamlining the processes, getting rid of redundancies and making care easier.
Now, are you connected with MyChart or is it ZocDoc? I think I saw.
Yeah, so ZocDoc is a scheduling platform, right? It's like Yelp for physicians, or I should say it's Open Table for physicians. You can jump on ZocDoc, find a doctor locally and schedule an appointment. So you can find me on ZocDoc, but if you go directly to the website, then you can book directly through me. There is a fee that I pay to ZocDoc, so I would always appreciate you coming through me rather than going through ZocDoc.
And in terms of your medical record, how do people access that? Is that connected with a portal of some kind, or?
Yeah, so the medical record system that I use is called Athena. Athena is one of the most robust medical record systems in the world. And the reason why they're so great is because they have their own portal, they have a telemedicine component, and they also have what's called an API or a bridge to other technology companies. So because of that, they're going to be one of the most innovative medical record systems that exist.
Well, Dr. Mayrsohn, thank you so much for joining us today. We are unfortunately at the end of the show, and we really appreciate all the information. I always say this, we always have great guests, but I know Kristina is going to be calling upon you to do some other kind of programming for Project Independence. So thank you so much for this hour of time. We are grateful. You're listening to Project Independence in You on LIU Public Radio.